Hello everyone. Today I am going to discuss about the management of status epilepticus. Many new things have been arrived for the management of status epilepticus, and there are lots of changes happened in the management part of the status epilepticus. The first change is in the definition. Previously we are think if the convulsion of a patient having more than 30 minutes, it is called status epilepticus. But now the definition has changed, and definition is divided into two time point, that is T1 and T2. What is T1 T2? I will discuss later on. First, the definition of status epilepticus is an ongoing seizure activity due to failure of mechanism responsible for seizure termination or initiation of mechanism provoking ongoing seizure causing prolonged seizure after time point 1, and which can give long-term consequences after time point of 2, including neuronal death, neuronal injury, and alteration of neuronal network. Depending on the type and duration of seizure, it is called status epilepticus. So, what do you mean by this status epilepticus? If a patient having convulsion more than T1 time of point, then it is called status epilepticus. And if the patient is suffering having convulsion more than T2, then it is time point T2, then it is the patient having long-term complication. So what is T1? Time point T1 is defined as the time beyond which body's inhibited mechanism cannot control the seizure activity, and the treatment should be initiated. That means when the conversion happened to any child or any patient, the body's inhibited mechanism is start to decrease the convulsion or control the convulsion. But if the body cannot control the convulsion, then if the patient, then we need to give some medication to control the convulsion. And this T1 is the time interval by which if the patient having more than this time interval of convulsion, then we call it is has the patient having status epilepticus. And T2 is defined as a time of duration ongoing seizure activity beyond which there are long-term consequences. Hence, treatment should be instituted aggressively to control the seizure. That means if the patient having convulsion more than T1, then we need to start the medication. If the patient is going to T2, then the patient will have some long-term complication of the convulsion. Now, what is the T1 and T2 interval in different types of convulsion? There are lots of convulsion, and the T1 and T2 are different in different types of convulsion. So, if the patient having clonic seizure or tonic seizure or clonic seizure, then or myoclonic seizure, then it is time point 1 is more than 5 minutes. That means a patient if having convulsion of tonic-clonic convulsion or clonic convulsion or tonic convulsion or atonic convulsion or myoclonic convulsion more than 5 minutes, then it is called patient having status epilepticus. And T2, that means if the patient having convulsion more than 30 minutes, then the patient having some long-term complication. These all are the MCQs for all India. If the patient having focal status epilepticus with impaired consciousness, the time interval for T1 is more than 10 minutes and for T2 is more than 30 minutes. So in some books it is written as more than 60 minutes, but in Nelson it is written more than 30 minutes. So it is, if the question comes to all India, then more than 30 minutes is the answer. If the patient having absence seizure, then status epilepticus is said if the patient having T1 more than 10 to 15 minutes and the T2 is unknown. So this time interval is very much important for all India MCQs. Now come to the management part during status epilepticus. When the patient comes to you in the emergency, always maintain the ABC of any emergency patient. ABC means airway, breathing and circulation. Put the patient in recovery position. So what is the recovery position? This is the recovery position. Put one hand of the patient under the cheek and put the one leg in flex position and roll over the patient to other side. This is the recovery position. You have to put the patient in recovery position when the patient comes to you in a case of status epilepticus, and see the airway is patent or not. If the airway is there is secretion, then securing the airway and suctioning, doing the suction to make the airway clean. Give the oxygen as early as possible. If a patient having convulsion, uh, the cerebral metabolism is increased. So that's why the requirement of the oxygen is increased in the brain. So you have to give the oxygen to patient as early as possible. Circulation, securing the intravenous access to make the patient to give the intravenous fluid, and also collect some blood samples like blood, doing the blood sugar, calcium, electrolytes, CBC, CRP, culture, and other things, and securing the intravenous or intraosseous access. You need to give the medication to decrease the convulsion or to subside the convulsion. So if the patient comes to you in your emergency, in the first 5 minute interval, you have to maintain the ABC, that means airway, breathing, and circulation. You check the blood sugar by heel prick or finger stick method, and do the IV cannulation, and take the blood sample for CBC, CRP, electrolytes, urea, creatinine, and do the ABG. If the patient having blood sugar less than 60, that means patient is suffering from hypoglycemia. It is written in Nelson. So age, then give the dextrose solution, and the conversion is due to hypoglycemia. So you need to give the dextrose solution. If the age is less than 2 years, then give 12.5% dextrose at a rate of 4 ml per kg bolus. And if the age is more than 2 years, then give 25% dextrose at a rate of 2 ml per kg bolus. If the patient do not have blood sugar less than 60, that means the blood sugar is normal, then go with the anti-seizure medication. That means the first line anti-epileptic drug. For the first line of anti-epileptic drug, it is preferred to give benzodiazepines, and the preferred benzodiazepine is lorazepam. If lorazepam is not present, then you can give midazolam in a slow IV manner, and the dose is 0.1 mg per kg. It is given slowly. Maximum you can give up to 4 mg. For midazolam, you can start with 0.15 to 0.2 mg. You better to give 0.2 mg, or maximum you can give 5 mg in a bolus dose, slowly IV, and it is given for 5 minutes. So after 5 minutes, if the seizure is not controlled, if the seizure is not subsided after first dose of benzodiazepine, you can give a second dose of benzodiazepine. So after 5 minutes, if the seizure is not controlled, then you can give a second dose of benzodiazepine. That means you can give second dose of lorazepam, midazolam. After 10 minutes and up to 20 minutes, if the seizure is not subsided, if the seizure is persist, then you go for the second line of anti-epileptic drug. There are lots of second line of anti-epileptic drugs present, but it is preferable to start with valparin or levetiracetam or fosphenytoin or phenytoin. There are no one is more better than other one. So you can give any one of the four. It is better to give valparin in more than 2 years of age child, and less than 2 years you can give levetiracetam. If the patient is suffering from any liver disease or any metabolic disease, better to avoid the valproate. So if a patient you are suspecting having metabolic disease or renal impairment, that means renal problem, better not to give valproate. It is a all India school. So avoid valproate if a patient having suspected metabolic disease or renal impairment, and you can give then levetiracetam. So the dose of giving valproate is in, you start with a higher dose, that means 30 to 40 mg per kg, or you can start levetiracetam in a higher dose, that means 40 to 60 mg per kg, slowly IV over 20 minutes. So you can start second line of anti-epileptic drug after 10 minutes after giving 2 bolus dose of benzodiazepine if the seizure is not controlled, and it is given for 20 minute infusion. So after 20 minutes, that means after giving 20 minutes of second line of anti-epileptic, if the seizure is persist, then there are lots of debates, there are lots of decisions is made. We can go to a start with continuous infusion of midazolam or an anesthetic drug, or you can go a second line of drug and other than what is given previously. That means if the seizure is not subsided after giving a first dose of second line of anti-epileptic drug, we can consider giving other second line of drug, anti-epileptic drug that is not administered earlier. That means if we start with, suppose we start with valproate, we give valproate to a patient, but the seizure is not subsided after 20 minutes, and the conversion is occurred less than 60 minutes. That means 60 minutes is the cutoff mark. Between 0 to 60 minutes, if the conversion is not subsided after giving second line of anticonvulsant drug, you can start giving a second line of drug. That means we can start levetiracetam for this patient. But if the conversion is more than 60 minutes, then we go to giving anesthetic drug, continuous infusion. So don't be confused. So first, if the patient is comes to you to 0 to 5 minutes, then give the first benzodiazepine, that is first line of drug, that is lorazepam. If the seizure is not subsided after giving first anticonvulsant drug, you can give a second dose of benzodiazepine. If the seizure is not controlled after 10 minutes, so you can give valproate or levetiracetam, whichever you can give. It is better to give valproate more than 2 years and levetiracetam in any patient for the first 20 minutes. So after 30 minutes of this, if the seizure is not subsided, and you can start giving other anti-epileptic drug in the second line list, or you can directly start giving midazolam infusion. So it is not better not to give midazolam infusion less than 1 hour of convulsion. So after 1 hour of convulsion, if the seizure is not subsided, that means after giving 2 dose of second line of drug, that means 2 different second line of drug, or you give 1 second line of drug in 1 second line of drug after 1 hour, the seizure is not subsided, you shift the patient to PICU, put the patient in mechanical ventilator and do the EEG monitoring, continuous EEG monitoring, and you start midazolam infusion. So it is better to start midazolam infusion after 1 hour of convulsion, if not subsided by giving anti-epileptic medication, and this is called refractory seizure. So what is the definition of refractory seizure? Refractory seizure means we start giving 1 benzodiazepine and we give 1 second line of anti-epileptic drug. So if the conversion is not subsided, after that we call the patient having refractory seizure and we start giving midazolam infusion, and it is the infusion rate is 4 microgram per kg per minute, and it is given in an increasing manner if the seizure is not subsided. We can give thiopental or we can give phenobarbital, propofol or ketamine or topiramate. So if after giving this anesthetic medication or continuous infusion of this benzodiazepine, after 24 hours, if the patient, the convulsion is not subsided, the convulsion is occurring for the last 24 hours, then we tell the patient having super refractory seizure, super refractory seizure, and we start some trial of other anesthetic drug which was not given during the previous step. That means if we give midazolam, then we can start giving thiopental or high dose of phenobarbital or propofol or ketamine for this patient. Or we can start some different treatment like ketogenic diet. This is all end ketogenic diet, pulse methylprednisolone dose, or giving IVIG or biologicals to some patient, or we can start vagal nerve stimulation or therapeutic hypothermia and epilepsy seizure in selected cases. These all are the MCQs. In which cases we can start this type of treatment, I will discuss later on. So, as a nutshell, for the first time, when the patient comes to you in your emergency with convulsion, for the first 5 minutes, you maintain the ABC, you check the blood sugar. If the blood sugar is less than 60, you give the dextrose bolus, or if the blood sugar is normal, then we start giving benzodiazepines over 5 minutes. If the seizure is not subsided after 5 minutes, you can give a second dose of the benzodiazepines up to next 5 minutes. That means 10 minutes. After 10 minutes, the seizure is not subsided, you give any 4 of the second line anti-epileptic drug, that is phenytoin, phosphonatoin, valproate or levipine, any one of them. It is better to give valproate in more than 2 years of age, and better to avoid the valproate in patient if the patient having metabolic disease or renal impairment. Best anti-epileptic is not all the 4 anti-epileptics are equally effective in case of convulsion, status epilepticus. So you can start any of them. The less side effect is present in with levetiracetam. So you can start levetiracetam in any age group of child. So after 20 minutes, that means for whole total of 30 minutes, if the seizure is not controlled, so you can add another second line anti-epileptic which was not administered previously for the next 20 minutes. So for the first 50 minutes, if the seizure is not controlled, then you shift the patient to PICU, put the patient in mechanical ventilator and do the EEG continuous monitoring, and the patient is suffering from refractory seizure. So you have to start the midazolam infusion at a rate of 4 microgram per kg per minute. And if the seizure is not controlled, so every 5 to 10 minutes you need to higher up the midazolam infusion, and you can give maximum up to 20 microgram per kg per minute. You can add thiopental, or you can give thiopental, high dose of phenobarbital, propofol, ketamine or topiramate in this time as an anesthetic drug for anti-epileptic for the epilepsy. So if the patient having convulsion more than 24 hours, you can give any other anesthetic drug which are not giving during the previous step, or you can do some different types of therapeutic options like ketogenic diet or immunotherapy like pulse methylprednisolone, IVIG or vagal nerve stimulation, or epilepsy surgery or hypothermia for the selected cases. So this is the treatment protocol for the status epilepticus management. Now comes to some few definitions which I described as earlier. So what do you mean by refractory status epilepticus? This is all in the MCQ, the definition. If the patient having status epilepticus after treatment of first line benzodiazepines and second line anti-epileptic drug like phenobarbital, levetiracetam or valproate or phenobarbital, so we call the patient having suffering from refractory status epilepticus. What do you mean by super refractory status epilepticus? That is If the seizure is persist more than 24 hours despite treatment of anesthetic agent like mirazole infusion or ketamine or propofol or thiopentone, then we call the patient is suffering from super-refractory status epilepticus. What is NORS? This is all India MCQs. What is NORS? NORS, the full form of NORS is new onset refractory status epilepticus. That means the patient do not have any epilepsy or do not suffer from any convulsion previously. So the patient having refractory seizure for the first time. So the definition is clinical condition characterized by new onset of refractory status epilepticus in a child without previous or active epilepsy or other significant pre-existing neurological disease or disorder like stroke, brain tumor, drug overdose, etc. and without any clear cause of the status epilepticus. So if we do not know any cause of the refractory seizure, we put the patient having NORS. And what is FIRES? So this is also an all India MCQ. I will discuss later on in my next video. So FIRES is also an all India MCQs. Now come when to stop continuous infusion of anesthetic drug. If the patient is the control seizure is controlled after giving anesthetic drug. So if the patient having status epilepticus in a refractory seizure, then we start, as I said, mirazole infusion. So after 24 hours of seizure period and EEG bus suppression, the both should be there. The seizure free period and EEG suppression, bus suppression is there. Then we need start decreasing the infusion rate at a rate of 1 microgram per kg per minute in every 3 hours. So after 24 hours of seizure free, then we can stop the anesthetic medication. Now some special situation in which we can give some special treatment if the patient having refractory seizure. So immunotherapy is given if the patient is suffering from autoimmune encephalitis, most commonly anti-NMDA encephalitis, or the child is suffering from CNS vasculitis or Rasmussen encephalitis. We can give immune therapy. What are the immune therapy? What are the pulse immunotherapy? That is pulse methylprednisolone or IVIG or some biologicals. So when we can give vagal nerve stimulation if the patient having catastrophic epilepsy in infant or epilepsy of partialis contiona. When to give epilepsy surgery if the patient is suffering from Rasmussen encephalitis. And what is ketogenic diet? When to start ketogenic diet if the patient having FIRES or Landau syndrome. We can give ketogenic diet. What is the ketogenic diet? It is a diet in which we give 4:1 ratio of 4 amount of fat and 1 amount of protein and carbohydrate. That is 4:1 ratio of protein and fat and protein plus carbohydrate, and it is given for first 3 days. So it is given for first 3 days till the patient is suffering from ketonuria. So it is ketogenic diet. So these are the all in MC. 4:1 in a ratio 4:1 ratio of 4 fat is to protein plus carbohydrate. This is the ratio in which we can give the diet for this patient, and it is continued till the patient is suffering from ketonuria. If the patient starts ketonuria, then we need to stop giving this ketogenic diet.